can ask questions as we come along and just stop me as you need to, okay?
All right, sure.
I'm Kristin Briscoe. I am an OBGYN. I actually practice at Advocate Christ. So I've been here for, I just had my 1-year anniversary this week. So I've been at Christ for a week or for a year. Before that, I was at University of Florida in Jacksonville, and then University of Florida in Keensville, and then prior to that, med school at IU, and then undergrad at Butler, which was an awesome place. So I've been around, you know, in Florida, and then now I'm back in the area and closer to family and really liking practicing, you know, at home. And I like winter, so I miss the winter. So I think it's really important to mention the reason why I chose this topic. People oftentimes say, I don't need to come in, like I don't need a Pap smear. Why do I have to come into the doctor? So I think it's important to kind of go through like why we do these exams and what we do, because we do a lot more than just your Pap smear. So let's see if we get the clicker working. Please note I have some cool transitions. So every year a woman should be seen by a gynecologist, whether or not there is every component of a well-woman exam, or whether or not there is, you know, a Pap smear, whether or not even there's a pelvic exam. All those things can be kind of tailored to where a woman is in her life, especially where a woman is like amongst her reproductive life, whether she's menopausal, whether she's starting her periods. We can kind of tailor things. Because we as OBGYNs have started doing long-acting contraception, we're seeing less people because they're like, oh, I've got my 7-year IUD, I'll see you in 7 years. So that's kind of contributing to why people aren't coming. And then also Pap smear screening, we've gotten a lot better at it, which is great. But some of the testing that we do is now like HPV and Pap smears, those only need to be done every 5 years. So again, people are like, okay, see you in 5 years, whereas that's not really what we recommend. So I think it's really, it's kind of hard to see with the white, but I think it's really kind of cool to see all the things that we do, even at just an annual visit. A lot of times that's a good place to plug in and start talking about any issues. So we talk about anything from like family planning, we talk about cancer screening and genetic screening. We talk about, honestly, I spend half of my well visits just talking about exercise. I need to maybe take a note and listen to what I tell my patients. I'm working on it. We talk about infertility, we talk about menopause care, we talk about menstrual symptoms, we talk about pre-pregnancy care, vaccines. You know, people actually come to the OBGYN more often. Women actually come to the OBGYN for 50% of their primary care. And while I don't consider myself a primary care physician, I think that's a role that I need to start leaning into and embracing, because that's why a lot of people come in to see their gynecologists. They think this is it, that's good. And that's the people that are actually coming in, not the people that are seeing us every 5 years. So I have started to kind of add some screening back, like things that a primary care physician would do, looking at lipids and looking at an A1C and looking at the thyroid. So that's one thing that I've started to change, because we've seen these changes and these shifts with patients and who they present to see. This one, you know, this slide, I'll go briefly over this. You know, family planning and contraception is a big part of what I do. So I see, you know, young girls that don't want to get pregnant. I see women that are, you know, in their like, I'm, you know, 40 and I really don't want any more kids. Please, doc, don't let me have a 40-year-old baby. So I see really a whole range of this. Up at the top, you guys can see on the slide, there's the implants and the IUD. Both of those are LARCs, that's the term that we use, long-acting reversible contraception. So both of those are implantable devices that can stay in place for variable amounts of time. The implant is the one in the arm, it's called the Nexplanon, can stay in place for 3 years, but the percent of failure rate is exceedingly low. I've actually never had a patient have a failure with the implant, so it's 0.05% failure. So again, it's very effective contraception. It's really easy to place, and a lot of people are really happy with it. It can also be used to treat several other medical conditions. We've also got the IUGs, which is the devices that are placed in the uterus. We've also shifted towards actually being able to place those postpartum. So a lot of my pregnant patients, I'm saying, hey, do you want me to just put this in while you've already got your epidural in place? And so I'm seeing a lot of people that are doing that, because it can be a little bit uncomfortable to place. And a lot of patients that are young and they're on TikTok and they're like, TikTok says that OBGYNs are bad and they don't numb us, but there's not really a way to numb someone for the IUD. It's just an uncomfortable procedure that is over quickly and you get better really fast. For me, I think it's worth it in the long run, because those IUDs can stay in place. Actually, they just approved Moran, which is one of our hormonal IUDs, to stay in place for 8 years. So that's a big deal. And then the copper IUD, which is another option, can stay in place for 10 years. So those are really big. And again, those are contributing to part of why women don't come see us very often, but they're really effective, really good tools. Other things, my husband would be happy if I mentioned this, vasectomy. My husband's a urologist. That's a great way for people to have permanent sterilization without a woman having to have a big major surgery. The vasectomy is an outpatient procedure. I did one as a med student. They are not that hard to do. So that is an option. And then we've also got female sterilization. We used to just tie the tube, as people say, like cut out a segment of the tube and then let women heal or burn or cauterize or put a clip. We're now so moving toward taking out the whole fallopian tube because that decreases the risk of cancer by about 66%.
Wow.
Yeah, a lot of ovary cancers actually start in the fallopian tube, and they've done a lot of research. Yeah, so we've really shifted towards that. But for my patients that have had a clip or a burn or something like that, that still does have some protective benefits, about a 33% reduction. So again, both of those are really good options, but I think we're moving more so towards taking the whole tube out. I also think that it leads to less bleeding postpartum, like less risk of, the tubes on time, for lack of a better word, or you're not slipping and then someone having bleeding. So we're really moving towards that. It's just a better procedure. We don't have really good data because that trend has been in the past 5 to 10 years, but I think we're going to see data that the failure rate of taking the whole tube out is going to be even less than 0.5%. I'm very certain about that. Then we have the less exciting birth controls below. We've got the Depo-Provera shots, the oral contraceptive pills, the patches, the rings. I had someone ask me for a diaphragm, and I'm like, I don't really do that. So that is an option. I don't know how to fit those, but some of my partners do. It's not asked for. It's not very common nowadays. And then we continue to go downwards as far as efficacy. We've got the male condoms, and then female condom withdrawal, the sponge. Again, none of those the sponge isn't as common. More often on this side of the world, we see the male condom withdrawal and then fertility-based awareness methods. The fertility-based awareness methods are actually getting better because a lot of women will, they have these kits nowadays where you can urinate on a stick and it'll say, hey, you're ovulating. So it's actually becoming a little bit more effective. I'd be interested to see if there's a change, or if there's like some data out there that shows that the women are doing that way, have a more effective cycle. So something that I personally need to look into, because I've had, my sister does it that way and she is great and she doesn't get pregnant unless she wants to. So I think there are some really effective ways to be hormone free and to monitor your own cycle. There's also a lot of apps out there. There's one called Glow. I can't think of any of the other ones, but Glow is one that helps you track your period. So pretty cool.
So why is the diaphragm not used much anymore?
I think I'm going to be honest, I think a lot of physicians aren't trained to fit it. And if you don't know how to fit it properly, it's not going to work. So I had never, ever, ever had anyone ask me for that so I've been in practice for 6 years. And then this year someone asked me, and I was like, well, I don't want to be the first one to fit it and then you get pregnant. So I think it's just kind of fallen off of the wayside as far as like people learning how to do it. And most of us are really promoting these longer acting, but I think it's something maybe I should learn to do now that I've been asked once. I should probably know how to do it. So I'll have to ask Dr. Starkowski how to do that. Breast cancer screening. This is a big deal, and this is kind of a hot button topic. So the American College of OBGYN, we call it ACOG for short. That's my people. The American Cancer Society, they have some different recommendations. So I'm going to really talk about ACOG because those are my people. That's how I like to do things. But ACOG actually recommends breast screening, cancer breast screening, starting at age 40 up until the age of 75. That is different than a lot of the other medical groups. And I think the thought is if you start screening at the age 40, we're more often to have, more sensitive tests. So we're more often to pick up like dense breasts or a nodule or something that is, maybe not a cancer, but then we have to go and test. So I think that the thought process of the other groups is that maybe we're doing a little bit more interventions. But the thought process of ACOG is that, 15 for the incidence of cancer is about 15% lifetime risk in females. So I think our thought is we better start screening early so we can be more aggressive. Because we've been screening at a younger age, we've seen a change in how breast cancer, the mortality from breast cancer since the 1970s has significantly dropped, and the life expectancy is much longer. I think in my notes here I have that their survival rate for 5 years was 90%, whereas it was 75% back in the 70s. And I think it's because we're screening earlier, we're much more aggressive. Yes, maybe we're doing more biopsies here and there, but at least we're finding these sorts of abnormalities. We do recommend a breast exam, age 40, every 1 to 3 years under age 40. I had a patient who was 40 that said, no one's ever examined my breast. And I said, oh, well, today's the day. So we do actually recommend screening less than 40. And then at 40, we really do recommend an annual exam. What we're looking for is really just, is there any lumps? Is there any bumps? Is your nipple, pointed inward? Is there any discharge when we squeeze your nipple? Do you have any lymph nodes up high that are dilated? There is breast tissue in the armpit. So if your OBGYN feels your armpit, they are not just trying to see if you're sweating. They are looking for some lymph nodes. And we used to, as a college, recommend breast exams all the time, when you're in the shower. We sort of moved away from that, and now we're recommending more so breast awareness. So if you notice something, pay attention to it. For my younger patients, is it related to your menstrual cycle? How long has it been there? Is it going away? For my breastfeeding patients too, how long has it been there? Is it going away? And if it's resolving, great. If not, definitely come in. Your OBGYN will do an exam. And then depending on your age bracket, if you're under 30, usually just get away with an ultrasound. If you're older than 30, you got to have a mammogram too. So we tend to do a little bit more diagnostic imaging rather than just the screening if you notice something on your breast exam. Even honestly, I'm a pretty cautious provider, and I think a lot of my partners are too. Even if I don't quite notice something, if you've noticed something, I'll generally do imaging just to be safe and make sure we're not missing something.
What about after 75?
I still recommend screening. So they used to say don't screen anymore.
Yeah.
But now there's a new shift in saying, hey, patients that are healthy and that are well together and that are well kept, continue screening for as long as it's reasonable. So, if I have someone that's 76 and she's got diabetes and she's, in the hospital and she's got end-stage kidney failure and her life expectancy is 6 months, I'm not going to make her get a mammogram. But most of my patients, they still get them. So if you come see me, I'm going to be stuck with them.
Oh, yeah. Yeah, I'm going to be 75 this year.
Oh,
so
happy birthday. Yeah. So I would still continue it.
Yeah, I had one this year already.
Oh, good.
Last year I had a callback, but it was apparently nothing. So
Oh, good.
you
Good.
always wonder when you get a callback.
I know.
But, it doesn't appear to be breast cancer in my family, so.
Good. And that is actually one thing that we're going to talk about too. Is that can really shift how aggressive we are with the screening too. I feel like you looked at my side, what's coming.
So what is the normal age to recommend aside from APAC? So APAC starts at 40.
40. I think American Cancer Society says 50 and they say biannually, whereas APAC says annually starting at 40. So it's that's a big discrepancy.
Sure.
But,
Plus I actually know personally 3 girls under the age of 30 who have died.
oh gosh.
Mm.
Yes. So, you just wonder what is causing that. Hi,
Yeah.
Welcome. No?
Well, you're perfect.
So that's why I'm almost wondering, should we even start screening earlier?
Exactly.
Growing up, never knew anybody who died of breast cancer, and now we just hear of it more and more and more.
And I'm wondering how much of that is environmental changes, changes in our
Exactly.
diet, changes in the way that we live, changes in the process things. I think everyone in this room can knows at least offhand one person that's less than 40. And so part of what we do is really increase who we're screening and increase we really try to focus on a family history. So we can say, oh gosh, you've got a cousin, a sister, a mom, and an aunt. We should probably do some testing and add additional screening. Another thing that we're starting to be a little bit more sensitive to is breast density. So how thick is the tissue around your breast? Women that have higher density are at a slightly higher risk of breast cancer. There's a really cool calculator, someone who's on a beach retired somewhere figured out, it's called the Gale model, and they can actually take into account how long have you been breastfeeding, have you breastfed, have you had kids, have you not had kids, when did your period start, when did your periods end, what's your height, what's your weight, all these risk factors, what's your family history, and it can say, hey, if we know that the average risk of breast cancer is 12%, your risk is 30%. And that may shift the way that we screen. So that's something that I think most OBGYNs aren't regularly using that as a tool, but we're all trying to shift into using that as a tool so that we can screen appropriately. And then the women that have dense breasts, in addition to just saying, hey, we're going to do your screening mammogram, we've started to add ultrasound too, because that can pick up things a little bit differently. And then in some women, we've added tomosynthesis, which is a different special way of doing the mammogram that looks at tissue a little bit differently. It has a higher sensitivity. And then some women that are really high risk, like with a history of BRCA, which we'll talk about a little bit later, we will do MRIs as well, like breast MRIs annually, and try to scatter those with mammograms. So I think one thing that's really neat is, I mentioned earlier I've been practicing for 6 years, and this has really changed even since I've been in practice. Like you can really see kind of a shift, and I think we're doing better for women, which like it's about time. It's about time.
As more women get into the medical field, that will happen.
Yes, ma'am.
It goes until 75. Can you explain why?
So that was, great question. So that was the previous recommendation. Now we're saying, and I think it's because life expectancy didn't used to be what it was. Now most of us OBGYNs, I do them all the time for my patients that are above 75. We had just talked about how if I have a patient that is like 60 and is, actively passing away from some other cancer that I wouldn't put them through a mammogram. But my patients that are in the 80s that are healthy, I do it all the time. So that's what the recommendation is. I kind of ignore that because I think that doesn't really account for how healthy our patients are nowadays. And again, how far we've come with, treatment of different chronic diseases and even improvement of, I think people have less, if we find a breast cancer, I don't think treatment of breast cancer is as difficult for patients if you find it early. So again, we're trying to be really aggressive about finding these things. So that has changed. Good question. The next slide, again, this is a beautiful picture of a Pap smear. So one thing that always happens to me is I'll have a patient who'll say, yeah, I went to the emergency room, they got a Pap smear. They didn't. They actually don't have the Pap smear supplies generally in the hospital. Like if I have a patient I'm doing surgery on and she needs a Pap smear, I gotta go run to the office to get the supplies because they just don't stock them. So a speculum exam is that duckbill device. A Pap smear is the duckbill device is in and we can see the cervix, but then we're scraping cells from the cervix and getting a sample and sending it. So I just think it's important to know the difference. And a lot of people don't because no one's ever taught them, no one's ever explained it.
Well,
So,
and it's not the most comfortable thing ever, so
correct.
I kind of blink and forget it.
It is unpleasant. I feel my OBGYN, I had a daughter last year and I got a Pap smear afterwards and she goes, oh my God, you are such a baby. And I said, I know. That's why I try to be really nice to my patients because I know this is an uncomfortable process. And I know, the devices make clicking sounds sometimes, or they're not as smooth when you place them. So I try to be really mindful and try to make sure that I'm using the appropriate size speculum and trying to make it more comfortable, although I know it isn't pleasant. And Dr. Sims invented this and he is in fact so. I think this slide is really pretty. It is also very hard to read. So I will talk a little bit about it. This is actually a Pap smear. So it's actually a really beautiful staining. It's infamous, right? We used to get Pap smears annually and that was that. And that's what we did. It's not annual anymore. We have different age group recommendations. The previous recommendations used to say, hey, you're sexually active, you're 12, but we're going to start doing your Pap smears. That's not the case anymore. We start at 21. The one exception to that is patients that have HIV or patients that have any kind of immunocompromise. So we do screen a little bit early in that special subset, but the average age we do not start at 21. So generally then we'll go between 21 and 29. We do it every 3 years and we just do a Pap smear, which is again, putting that speculum in, using that cyto brush, and then we send the cells to pathology doctors. They now have technology that can kind of screen, okay, this percentage of cells are abnormal, this percent are normal, and it will kind of grade where you are, which will lead us as an OBGYN to make a recommendation based on what the next step should be. And sometimes it's, hey, repeat in a year, and sometimes it's, hey, we need to explore this a little bit closer. We might need to do a biopsy, we might need to look with a microscope. So that technology is a lot better, and I think the next person you can see, the age group 30, we actually do that with HPV testing. And HPV testing is a big thing that's coming up now. And that really started like 3 years ago, but it was a huge button topic. and some places actually will just do screening just with HPV every 5 years. We don't have that specific test because it's very specific, FDA approved looking for HPV, which stands for human papillomavirus. So, you can see in the very young groups, so you don't do it 21 to 29, we do it every 3 years, and then 30 and above, we do it every 5 years if you do it with HPV testing. Some people though just say, hey, no, I just want my Pap smear every 3 years. I don't want the HPV testing. And I say, okay, that's great. We can do that too, because they're equivalent at catching, and detecting cervical cancer. 65, we don't have to continue to screen women. So that's actually one thing that's great to be able to get out of, because it's very unlikely for women at that age to develop a new onset HPV infection. That being said, there is a caveat. My women that have had a high grade risk or a high grade abnormality, in that, if we stratify things on a level 1, 2, and 3, women that have had a level 2 or 3 need continued screening for at least 20 years after they're abnormal. So you're stuck for a while if you've had an abnormal. The other thing to note that's important is people often ask, well, I don't have a uterus anymore. Do I need it? I've had a hysterectomy. Like, why are you going to do this to me? Well, women that have a hysterectomy that have the level 2 or the 3 abnormalities, they need to be continued for at least 20 years as well and making sure that they're normal. The only other thing is I have PAP'd a 75-year-old, I have PAP'd an 80-year-old, because some women haven't had, OBGYN care in 30 years, and I don't want to miss something because I don't want to just assume that they've been normal in that time. So in that age population, I will continue and I will continue to screen regularly until we get to the 20 years. So say, for example, I've got a new patient, she's 65, she hasn't seen an OBGYN since she had her daughter at 21. She's stuck with me for 20 years of Pap Smear screening, and that's the right thing to do, okay? Any questions on that? Oh, my only other thing is cervical cancer is the third most common GYN cancer after uterine and breast cancer. So it is really important to screen. We're really fortunate in the United States that we have this testing. Other countries that don't have cervical cancer screening, the incidence is a lot higher. So I think we're really moving things forward for women, and we're actually doing things a lot better because we're detecting these cancers early. And these abnormal changes, cervical cancer doesn't happen in one day. It tends to happen over the course of 9 to 10 years. So we're able to catch things at maybe the 3rd year of an abnormality, treat it, and then continue to monitor. The only other big thing that I will mention about cervical cancer is it doesn't tend to be hereditary. And that's, I think, another misconception in the United States. So if your mom, if your cousin had cervical cancer, it doesn't tend to be hereditary. It tends more so to be related to the virus HPV. That is a very common virus. Somewhere on the order of 80 to 90% of women are exposed at some point in their life. So it is really important to know that that's one of the risk factors. And then tobacco smoking is also a risk factor for cervical cancer. And then those two things in conjunction really increase the risk. The other thing that really increases the risk is multiple sexual partners over a lifetime. And again, I think that's just because more chance of encountering HPV. So that really circles back to HPV. And then, I'm missing something here. Smoking, tobacco. Those are really the big things. Hi.
Hi,
Come on
I
in.
think I'm at the wrong program.
Oh gosh, where are you trying to go?
Something about genealogy.
Oh.
Downstairs in
Downstairs.
meeting room B,
There you
Can I
go.
get down over there?
over on the other side.
There you
Yep.
go. Have a good one. Oh, that's just kind of fun. So the next thing to talk about is genetic screening. And again, this is pretty cool. There's some really good applications or some that are maybe not so great, but I think one thing that's important to know about is carrier screening. So if you think about a gene, if you think about you have stuff from your mom and your stuff from your dad. So I like to think about 2 letters. Some traits are autosomal recessive, meaning that mom has to be a carrier and dad has to be a carrier for someone to have an affected baby. So things to think about like that is cystic fibrosis. So I'm a cystic fibrosis carrier. I don't have cystic fibrosis. I have the gene. If my husband had the gene as well, or if he was a carrier, then we had 1/4 the chance of having a kid with cystic fibrosis. So he's not, my daughter's fine. But it's important to know these things, especially before pregnancy. We can see higher risk patient groups, so Ashkenazi Jews especially, they tend to have a higher risk of some of these genetic diseases and genetic conditions. So we really offer screening even before pregnancy for these patients, and they have whole panels of genetic diseases I've never even heard of. And so patients that maybe have a similar background can confirm like, hey, we don't have 20 genetic abnormalities that are the same. We can probably have a kid safely. For some patients though, like my best friend is Jewish and her partner and her, they did the testing to ensure that they didn't have any similar genetic abnormalities, just to make sure that if they had a ton, they could talk about doing reproductive endocrinology to ensure that they don't have a baby that's affected. So that's one thing to do before pregnancy. During pregnancy, we tend to screen for cystic fibrosis, sickle cell disease, or traits. And then we also tend to screen for something called spinal muscular atrophy, which can be fatal. So it's really important to do these things. And I always offer patients that want to get pregnant to do these testings beforehand, Because if they're affected, then we can test their partner and then we can see what the likelihood is of them having a child that's affected. So
Is this a blood test?
correct, it's a blood test. Mhm.
My daughter-in-law is now pregnant. She's just about 5 weeks.
Oh,
And she
congratulations.
was gonna have a blood test. She's 37.
Oh, yeah. She should get, there's something called self-revealed DNA. That's the best one. I bet she'll get that.
I'm sure it is. I mean,
Yeah.
she's considered high risk because of her age.
I know, it's a mean term. We all say it.
So, yeah, but my son was telling me, well, they're gonna, find out what the baby is.
Yes,
But
yes.
I'm thinking, there's gotta be other stuff they're doing with this blood test.
I'm sure there is. So actually you bring up another test. It's called self-revealed DNA. So this test is really cool because it tests for trisomy 21, so Down syndrome, tests for trisomy 18 and trisomy 13. Both of those are fatal anomalies. As you guys know, we all know someone with Down syndrome, so that one isn't fatal, but it is important to diagnose these things. Detects these abnormalities with a 99% detection rate. It's really good. The only downside and the only caveat, and the reason that I like to counsel patients about this is it's not 100%, right? So if there's an abnormality, we often recommend follow-up testing. Now, some people will say, that's good enough, at least know. But some people will say, hey, I'd like to have a confirmatory test. And that would be something like an amniocentesis, where a high-risk OB physician, I did a couple in residency, but I'll do those now. The high-risk OB physicians do those. They take a sample, they will clean the area, and they'll take a sample of the amniotic fluid and send that off for genetic testing. So they'll do a little bit of, that is the only way they get definitive tissue, but that's something that we do if there is an abnormal. But it's a very good test. I did it myself. It's a great test. I would recommend it for everyone. We used to have a lot of trouble getting it covered unless people had an indication. So a prior pregnancy with complications, or, they were, the term advanced maternal age. But now we're starting to see more and more insurances cover it, or at least make it available. I think for me, it was like $85 copay. To me, it was worth it. So depending on, actually Medicaid has stepped up and done a really good job. And they're the only insurance that really just lets me do it on everyone. So good job, Medicaid. It's not really reasonable to not offer the best screening test that we have. We do have 2 other screening tests that test for, the one other thing that the self-revealed DNA has besides those things is it can test not as high accuracy, but it can also test for like gender disorders. So XO is where there's only one gene and it tends to be a female. So it tests for that, tests for like XXY, it tests for these other syndromes with not as high accuracy as the other things, but it's kind of nice for them to get to know gender too. So that's a nice bonus.
So you can tell gender from a blood test now?
Yeah, it's really cool. It actually is testing for fragments of the placenta in maternal blood, which is like very cool. We do have to wait until 10 to 12 weeks to actually do it because there's not enough fragments. And if you come up with insufficient fragments, they tend to have to repeat it.
Well,
So
my son did say that
did they do it
she
already?
did it already,
Okay.
and she's only 5 weeks.
Wow. Maybe
So-
there might be a better test out there because I just have like the
I don't
basic.
know what they did.
Yeah.
That's just what he told me.
There might be like a higher sensitivity. I'm sorry, I just dropped this. Gosh, panic. There might be a test out there that's higher sensitivity. So there's that too.
I have no idea.
Yeah. I mean, I have some reading to do there.
I'll
Give me
have to
some more.
check.
Hi, welcome.
That's fine.
Oh yeah, please sign in and then just take a seat anywhere. We're happy to have you. Other like genetic testing that we can do in pregnancy. So I already told you about the best one. I told you the one that I recommend for everyone. These other 2 are okay. There's something called the first trimester screening, which is where we measure behind the baby's neck on ultrasound, and then we send some blood analytes. It has about an 80% detection of any of these abnormalities, as the Down syndrome and the other trisomies. The other test is something called a quad screen, which is you test for 4 blood analytes. And later on in the pregnancy, again, it only has an 80 to 90% detection. So I really steer people toward the other one just because, like, why wouldn't you want the best,
And what is that?
The quad screen, those other, it detects the Down syndrome, the trisomy 13, the trisomy 18, both of those kind of pick those things up. And then we're getting, it's not me. Our MFM doctors, our high-risk doctors are getting really good at ultrasound. So they're detecting abnormalities and things that previously weren't detected. So now they can actually combine when they're doing their ultrasound. If there's been an abnormal test They're gonna look for, does the heart look okay? Does the, are the bones forming the right way? Is there any kind of misshape in the brain? So they're really getting good at this stuff. And I'll be honest, you get a little bit of training as a generalist, but if you showed me a picture and said, is this normal? I'd say, no, not sure. So that's why they go to school extra and they get paid the big bucks. So we do have some really good, and they're here at Christ, we have them, they're like our neighbors, so you can always go and ask them a question, which is, and we work really closely with them because they see our high-risk patients, but we do their deliveries. So it's a pretty nice symbiotic relationship there. As far outside of the genetic screening, besides just the pregnancy stuff, there's some other really big players in the game. So I'm sure everyone knows who Angelina Jolie is. She's big lips, beautiful. She actually has BRCA, and I remember learning that in medical school, and that was the first time I really heard about BRCA. I didn't really know what it was, but this is a hereditary breast cancer mutation. And interestingly, our body has some checks and balance systems, and the gene for BRCA tends to say, hey, these cells are abnormal, stop it. So it's a tumor suppression gene, and it'll say, these cells are abnormal, we gotta stop dividing, like this is no good. People that have the BRCA mutation, they don't have that ability to stop and say, hey, the cells are abnormal. So the abnormal cells just continue to grow. The BRCA actually will set patients at a much higher risk for breast cancer and for ovarian cancer. Somewhere along the order, it's kind of a broad, this is a broad number, we gotta get better at it, but the number for breast cancer is 40 to 80%. A lot of literature cites 75% in both BRCA1 and 2 for breast cancer. The risk for ovary cancer tends to be about 20% in BRCA1 and 10% in BRCA2. So still very high numbers. Other things that patients that have BRCA2, men are affected too. So oftentimes we'll hear a history of prostate cancer, we'll hear a history of male breast cancer, which is about 6% in BRCA2 carriers. So you see a lot more male breast cancer, which isn't something that we think about every day. A lot of these, a lot of women that have this say, gosh, I don't want to know. Why would I want to know? Well, there's a lot of reasons to know. So we can actually do different kind of procedures to decrease the risk. So nowadays we're actually talking about doing mastectomies and taking out the breast. I don't do that. I send you to the breast surgeon and they do that, and they do a really nice job. And sometimes they'll do a surgery even where they take out, the breast tissue and send it, make sure there's not any kind of cancer, have the, the plastic surgeon come and put in expanders and then subsequently do a breast reconstruction. So that's a really good thing to do. And that decreases the risk of breast cancer by around 80 to 90%. So it's a big deal to get that performed. The other thing that we do is we can do something called a risk-reducing salpingo-oophorectomy. That is a mouthful. We take out the tubes and the ovaries, and that decreases the risk of ovarian cancer. Like we mentioned earlier in the talk when we talked about fallopian tube, when we take out the fallopian tube in entirety, that decreases the risk of ovary cancer by along the order of 60%. So if you think about taking out the full tube and the full ovary, man, oh man, does that really decrease your risk? It reduces it by about 80%. So again, even these women that are really likely to get these cancers, it really decreases their risk. The other thing is, when do we do this procedure? Taking out your ovaries and they're going to menopause, that kind of stinks. But it's better to live. So we actually start doing these procedures early, so around the age of 35 to 40. So it's important to diagnose these women. And then when when someone screens positive for this, we actually do more invasive screening. So earlier we talked about the mammograms and the MRI. We start doing annual mammograms. I forget the number. We start doing mammogram or the MRIs at age 25, and then we add in the mammogram and we do one every 6 months. So these women that are at a really high risk of breast cancer get screened a lot closely, okay? And then just that's the rate of incidence in the general population. BRCA is 1 in 300, BRCA2 is 1 in 800. So it's actually, it's pretty good. Everyone probably knows someone with BRCA. The way that we decide who we're going to screen is, once again, we take that family history, and that's really important. So people that have a family history of someone with prostate cancer or someone with male breast cancer, or my mom and my sister both have breast cancer, or my mom and my sister have breast cancer and they were BRCA positive. We have a kind of screening algorithm for who really should get testing. And once you have a positive test, we often will send you to genetic testing. Sometimes we'll even send you to genetics before to determine if you really want to know and if you really want that burden. I actually am really advocate for knowing, especially in this, because there's so many things that we can do to improve outcomes. Okay. So lot of information on this slide. Not a very pretty slide either, sorry guys. Health maintenance. So I think this afternoon I saw 3 annual exams. So patients got to hear me once again talking about all the exercise that I am not doing, but I'm working on doing. Generally, we recommend patients exercise for 30 minutes, 5 days a week. Now, I'm not saying you've got to go out and crush, pump and iron, but it is important even just to walk 30 minutes a day. We found that people that wear exercise trackers tend to do better at exercising. Not me, not today. But we know that women that have this have kind of an accountability. It also bullies you a little bit. My message to me an hour ago was like, you're really behind on your numbers. I said, okay, thank you. But there's been some studies that suggest that women feel a little bit more, and men too, as people are a little bit more accountable if they have an exercise tracker. Other things to know, people ask me like, is walking good? Yes, walking is huge. So patients that, tend to be a little bit more sedentary, once they start walking, that really causes women to lose weight and to get into better health. The other thing to know is that it's not just about like your weight and all that stuff. Exercise overall, I can't think of an organ system that isn't helped by exercise. I was actually looking with my husband at this slide. I said, Kevin, look at this. The amount of things, I wrote them all down here in my little notes, that it does. Decreases all-cause mortality, decreases cardiovascular disease, decreases hypertension, decreases type 2 diabetes, decreases most cancers, decreases abnormal lipids, decreases dementia and improves cognition, decreases anxiety and depression, improves your sleep, slows your weight gain, causes weight loss for those who need it, prevents weight gain after weight loss, improves bone health, decreases fall risk, decreases fall-related injury, decreases gestational diabetes during pregnancy, decreases excessive weight gain in pregnancy, and decreases postpartum depression. That's a lot. I didn't memorize a lot. I had to write it down, as you guys saw. So it's a lot of health benefits. And I think, talking about this now, I'm like, okay, I got to go on exercise. But it is really a beneficial tool. In women, the thing that's important to know is, yeah, it's great if you're on the treadmill. It's great if you're on the elliptical. That's really good for your heart. But things that are bone protective are going to be your weight-bearing exercises. So your squats, even if you have like a 2-pound dumbbell and you're just curling while you're watching a show, that improves your life expectancy and increases your bone density. Kind of a sad fact, we are all at our peak bone density at the age of 19. We're all just want to assume we're all about the age of 19 in this room, so we're all past our prime, ladies. So this exercise bit is really important. The other thing to know about that is that the other way to decrease the weak bones and osteoporosis outside of that exercise is calcium and vitamin D. I think I could probably test all this in this room and we would all be vitamin D deficient. I think that's a product of living in Chicago. Well, honestly,
Not
not
you.
you? Hey, good job. Okay, so you're the one. You are it. You're a survivor. That's amazing. I will say like 75% of my ladies vitamin D deficient. So you're doing good.
Do you take supplements?
Yes, I take supplements.
That's
yes,
right. That's
but
your duty.
also your diet,
Yes.
everything on your diet,
Greens, you eat a lot of
your
greens.
diet,
Mhm. Your diet and your supplementation is good. So
raw, need live food for a live body.
you do. You need all your fruits and vegetables, all of your your kales and your greens, all that stuff is really good. As far as supplementation, I take a supplementation because I know I'm not getting outside enough. I'm probably not the best with my diet. We usually say 2,000 units a day. And that just is on the bottles over the counter. And any pharmacist could help you with that. But again, that important number is 2,000. As far as calcium goes, kind of depends how much your dietary intake is. You don't want to get, my husband, the urologist, he'd get mad at me. If you take too much calcium, you can increase your risk of stones. So if you're someone that's like a cheese eater like me, you probably don't need as much calcium. Love cheese, love my cheese, love my dairy. But generally we recommend something on the order of 250, and I'd have to look that up. I'm so sorry, I can't remember that off the top of my head. I didn't write that one down. But I usually will just send it. There's a lot of really cool pills in the pharmacy that are a combined chew that has calcium and vitamin D. And that's what I generally recommend my patients to take because then you get it all in one. And sometimes they come in a fun little chocolate flavor. We also talk about visiting a dentist. This is not a plug for my father. He's too far away, but he is a dentist and he is very passionate about women getting their teeth cleaned, especially, it decreases the risk of heart disease. It also, in my pregnant patients, decreases the risk of preterm labor. So big deal, gotta go see the dentist, and we usually will bring that up at your annual exams. I always encourage sunscreen. I don't care how pigmented you are. My husband, who is Indian, always takes my good sunscreen, and I'm like, oh, that is like $50 a bottle. Use the stuff from Walmart, but I'll let him use it because I don't want him to get skin cancer. It's definitely important. We always talk about wearing a seatbelt. It's a lot better now that the cars just yell at you and you have to put your seatbelt on. But again, that is a big important. And then the kind of tough part, which unfortunately sometimes comes back, is we generally will screen for domestic violence. We're really lucky at Christ. We have a really good social worker that is honestly like if you could meet a Disney princess in real life, that would be Allison. She is the most kind and loving and caring person I've ever met. And she is someone that really helps us plug patients in and give patients resource. And so that's something that we try to do annually at an exam as well, because it is important. The next thing we talk about is infertility. So a lot of women will come and be like, hey, I've been trying to have a baby for 4 years. Why can't I? Well, you're right, that is a long time. So generally we define that as 12 months of women that are having regular unprotected intercourse. And I hate to say this, but in the vagina, because some people don't know that it has to be in the vagina, in a woman that's less than 35 years old. You wouldn't believe the number of people that say, oh, I did not have to be that way. So I always like to clarify that. And then Moran, yes, I promise you, she got pregnant after we talked about that. So that's good. 6 months of regular unprotected intercourse in a woman more than 35. Yeah, I promise you. That is not because, that is honestly just because we know that women can have higher, honestly, it's a beat the clock sort of thing. So once you're past 35, if it's more than 6 months, we do recommend getting a fertility treatment. So infertility, the way that I like to think about it is there's 3 things that have to happen. You gotta have a sperm, you gotta have an egg, and you gotta have a way for them to meet. So the on this diagram, you can see you've got your uterus, you've got your fallopian tubes, and then over here, your ovaries somewhere. So generally every month we ovulate, the egg comes in through here, the egg and the sperm meet together, actually in the tube, fun fact, and then they come together and implant in the uterus. So if there's any hitch along the way, you're not going to get pregnant. So there's.
I would love to if I could, but.
Not presently, hopefully soon, but. So fair.
Rich, if you do. We're wealthy.
So we look at generally, if we're like working up infertility, we look at 3 things. We look at how is the ovarian reserve, like are you ovulating? And there's a couple of labs that we do. AMH is like an ovarian reserve tester. FSH is like, I like to think about is that is the hormone in your brain screaming at your ovaries, make an egg. It stands for follicle stimulating hormone. So it's yelling, make an egg. If it's shouting very high, and your ovaries not responding, that's a sign of menopause. So if it's a really high hormone level, probably in menopause. And then we look at your estrogen too. Generally, we do those between days 3 and 5 of the menstrual cycle. We also look at the fallopian tube in the uterus. This picture is a picture of a hysterosalpingogram. It's an X-ray of the uterus. So we inject dye in the uterus and we take an X-ray with the radiologist, and we're looking at, is there an abnormal shape to the uterus, and are those tubes both open, and is there dye spilling out of both of those things? There's different ways to evaluate the uterus lining. I think by far this is the easiest one, and it's the one that I can most often get insurance to cover. So that's why I like to do it. And then the last thing is a semen analysis. I don't do that. I send patients to the reproductive endocrinologist, and then they usually communicate with me. Some of these things as a generalist, like this is kind of the workup for a general OBGYN who covers a broad topic. Some of these things I can work with. Like if someone has, open tubes and their semen analysis was normal, but maybe they're not ovulating regularly, I can give medications. But if the tubes are blocked and the sperm are great, or the ovary function is very low, that's when I would send to my friends that reproductive endocrinologists. Menopause care. So the average age of menopause is 51 in the United States. A lot of women actually will have symptoms for a year beforehand, and sometimes up to 10 years after they go through menopause. So it's not the one and done process that people tend to think it is. The formal diagnosis is, hey, you've had a year without menstrual cycle. That becomes a little bit more challenging in women that have had a hysterectomy, but in that case, I generally will combine symptoms, vasomotor symptoms like hot flashes, mood changes, and then kind of look with the hormone, that FSH hormone that we were talking about that's screaming at the ovaries, and we can diagnose it based on that. So again, it's a little bit more challenging when women don't have a uterus anymore, but if you have a uterus still, generally we diagnose this after 1 year of without menstrual cycles. Big symptoms that most people talk about: hot flashes, vaginal dryness, and mood lability. And those are the biggest complaints I get. Occasionally I'll get headaches or some other complaints, but these are the 3 big hitters. A lot of times, in women that have normal lipids and women that are within 10 years of starting menopause, that's a great candidate for hormone replacement therapy. Women that are outside of that timeframe tend to have higher risk, and it's not a great idea to start. But the good news is we've found out other medications that are really good at managing these symptoms. SSRIs, like selective serotonin rate uptake inhibitors. So are also known for antidepressants, but they have really good efficacy and really good data on working for hot flashes. Gabapentin is a medication that people often use for nerve pain, also very good for hot flashes. And I have a family member that's on that presently. So there's a lot of good tools that are not just hormone replacement therapy that include patients that perhaps aren't a great candidate for that. So that's one thing that we like to do is just that systemic hormone for patients that say, man, I feel great, I'm not having hot flashes, but I'm having a lot of vaginal dryness. Those patients, as long as they don't have any abnormal bleeding or any other issues, are a great candidate for vaginal estrogen. And so that's something that I start a lot of my patients on, as well as a vaginal moisturizer. There's one called Replens that works really, really well. And then mood labilities, some patients say, hey, I'm hanging, I'm dealing, but some patients want a referral to, therapy or counseling, and some patients also want to start an antidepressant, which also works with the hot flashes. So just tailoring to see what patients like. I have someone actually that was hot flashing and had mood lability and wasn't a great candidate for hormones, so she picked paroxetine, which is a really good medicine that covers both. It's actually FDA approved for hot flashes, so we got her on that. She's feeling a lot better. So there is options out there. The big home hitter on this slide, and that's why I made it pink, bleeding is not normal after menopause. It's just not. It's oftentimes a warning sign. Now, we sometimes do see it on patients that are on hormone replacement therapy, but I still recommend getting evaluated by your OBGYN. The way that we do a workup for bleeding after menopause is two things. Number one, an ultrasound. What are we looking for? We're looking to see if your uterus lining, that fancy way that we call it as the endometrial stripe, we're looking to see if that's thickened. If it's more than 4 millimeters, 5 millimeters now, that means we probably need to do some sampling. And then oftentimes we'll do an exam and see, sometimes women will have a polyp, which is just like a little skin tag. If that's right at the cervix, then I can just take it out and that will likely stop the bleeding. But the ultrasound will help guide us. If the stripe, that thickened lining, is less than 5 millimeters, 4 or less, I guess, the risk of cancer is less than 1%. So pretty good odds. So if someone has a stripe that's less than 4 millimeters and equal to or less than 4 millimeters, then I can say, hey, let's continue to observe. But if you continue to have bleeding, that's when we move towards doing something called an endometrial biopsy, which is sampling of the uterus lining. And we can do that when you're awake in the office, or some of our patients are like, hey, doc, I have had enough discomfort in my life, put me to sleep. And I say, okay, you got it. So we can do that in the operating room as well. Okay.
Do they still recommend hormone replacement therapy for older people?
So great question. So they now have really shifted towards, if you start it within the first 10 years of menopause, you will have better outcomes, right? So it'll help decrease the risk of cardiovascular disease, which goes up after your, after your menopause. They have found though, if you don't start it within those first 10 years and you start it later, it increases your risk of those things. So it's kind of a two-hit hypothesis.
But they were saying to stop it because it created.
Oh,
heart
yes.
disease.
Yes, so in someone that has started within those 10 years, they can continue it as long as they want, knowing that there are still some risks of being on hormone replacement therapy, knowing that there's a risk of stroke, knowing that there's a risk of blood clot. Although my kind of like common sense argument for me, at least, what I think is that if you've been on it for 10 years and you're still okay, I'm gonna refill your prescription and let you go on
I
your way.
felt great when I was on it,
Yeah, did they stop you because they
They
said it was
did.
too late?
but I'd love to be back on it.
And we will have to talk. I think it's really great. And I think I'm trying to get my patients to come to me more like right when they're in menopause so that we can start it, so that we don't have that risk of like starting and then stopping and then coming back on, or, starting really late and then seeing those increased risk of cardiovascular disease. They did this big trial called the WHI, and that was really where we got a lot of our data on, but they were starting it on 80-year-old women that had, they've been out of menopause for like 30 years. Not your best plan to just start putting patients on that without ever having them stop it. And so then they kind of extrapolated the data and they did something called the nurses something initiative, you should know that, where they looked and they actually stratified, okay, if you're younger, let's start you here. And then they saw that decreased risk in heart disease for women that started. My personal suspicion is that once you stop it, and then it's been a prolonged amount of time, and then you decide to start hormones with more than 10 years, that's when I think you would start to have some of those issues and that risk of heart disease. And I think it's because your body has adjusted to having more estrogen, and then you're starting estrogen again. And just like women on birth control, with estrogen and progesterone, you've got that slightly higher risk of blood clot. Not really progesterone, but estrogen. So I think I think that's something that we're still working on studying, and this is an area where we need to do better for women, but we're working on it. There are a lot of data out there, and there's actually something called the NAM Society, the North American Menopause Society, and they are wonderful advocates, and they put out, honestly, I was podcasting to them on the way here, they put out lots of podcasts and lots of new data, so I think things could continue to change in that. I think it's not a very well-studied area, and I think we're all working on it. And I'll tell you one thing too, in training, myself even, most of my patients were pregnant or they needed a hysterectomy. I didn't see a lot of menopausal women in training, right? Like a lot of menopausal women aren't like, I'm gonna go see a resident who doesn't know what she's doing and learning, like they've been there, done that, right? So I think that there's like a gap in knowledge that is, when you're in your first couple of years of practice, you start to pick up that knowledge. And I've worked with some partners that are more experienced and saying, hey, what's the best regimen for this? And so I think that that's something that we need to do better on too, is training residents that are learning how to do this kind of care. One other caveat here is bioidentical hormones. People always ask me about that, like, hey, bioidentical hormones. Those are compounded hormones that are supposed to mimic what is in your cycle. They are not FDA approved. The only bioidentical hormone that is FDA approved is a micronized progesterone. We will oftentimes use in women that have miscarriages or women that have shortened cervixes. That is the only one that's FDA approved. So most OB/GYNs they're not really on the bioidentical hormone bus. And I am not in that camp either. I was also listening to a podcast about that. Really like my podcast, you guys. The next thing that we do as OB/GYNs is talk about menstrual concerns. Normally a menstrual cycle is every 21 to 35 days. They last 5 days, plus or minus, right? On average, women lose 85 cc's of blood. That's not a lot. We have this really cool acronym called POM-COIN. That's different reasons why people have abnormal uterine bleeding. The first word is really structural causes, so polyps, those skin tags that we talked about. Adenomyosis, that's actually a condition where the lining of the uterus gets into the wall of the uterus. That can cause really bad pain, can cause really heavy bleeding. That tends to happen in women that have had children. Unfortunately, we're not great at detecting that on imaging. We can see something suggestive of it. The only way to really diagnose it is to look at the uterus under a microscope. So we generally will diagnose that more in my patients that have had a hysterectomy. L stands for leiomyoma. Another word for that is fibroid, fancy word. M is for malignancy or cancer. C is for a kind of coagulopathy. So sometimes people that have bleeding disorders will see heavier periods. O is for ovulatory, so patients that are really young and first starting their period, their brain isn't quite there and they don't get the signal to ovulate every month. So instead of shedding their uterus lining builds up really thick and then just bleeds randomly. And so these patients will have really heavy periods. And we see that often in my teenagers, and then we also see that in my patients that are approaching menopause because they don't have the egg reserve, so then they're not ovulating and then they're having really heavy bleeding. Other people that we see this in are patients that have polycystic ovarian syndrome, patients that have kind of ovulatory dysfunction. They're not ovulating regularly. Their uterus lining is really thick. They're bleeding sporadically. And then the I is iatrogenic, so sometimes medicines that we give you make it bleed. The E is endometriotic. I don't really know what they're talking about. No, I'm really what they're talking about there. And then the N is not otherwise specified. So we really stick mostly to the POM-COIN. We do a lot of workups for this kind of stuff. Generally, if I see someone in the office, saw someone today, what I did was I recommended an ultrasound so you could characterize your uterus, see if there's something structural. I recommended an endometrial biopsy, which is sampling with a straw and the lining of the uterus. We don't make everybody do that, but patients that are higher risk, we often will do that. And then I do a lot of blood testing, making sure they're not anemic, testing their thyroid, making sure that they don't have diabetes, doing a Pap Smear, because sometimes that can cause abnormal bleeding if you have cervical cancer or cervical abnormalities. And then chlamydia can make you bleed too. So doing STD testing and then doing a pregnancy test too, because sometimes early pregnancy can lead to bleeding. So that's kind of a brief overview. I could talk for hours about that. I will not hold you guys hostage for that. It's one of my favorite topics. So, and again, I won't hold you guys hostage for this too. Pre-pregnancy care, we do a lot. We recommend patients, especially patients that are higher risk, to come in and see us before they conceive. Oftentimes we'll look through their risk factors and we'll say, hey, you've got a seizure disorder, you probably need to be on Orfolate. So we really like to look through their medical history, their medical problems, look through their medications, make sure they're not on any medications that can cause abnormalities. And then we really like to optimize patients' medical problems before they conceive. So patients that, for example, have Crohn's disease or some kind of autoimmune disease, if you can optimize that before pregnancy, they tend to have better outcomes. So we do a lot of that. Usually we'll go through immunizations. We'll make sure that they're not in a place where they're touching cat litter, which could, cause a toxoplasmosis virus. So we're really like looking through and trying to make sure that patients are at their healthiest before they get pregnant. And that's really honestly what we do at these preconception visits. My big thing is if you have a family member that's trying to get pregnant, make sure that they are taking a prenatal vitamin for at least a month before they conceive. That will decrease their risk of having a neural tube defect. Okay. So again, this is more all that, and a lot of this is kind of common sense, like don't drink, don't smoke, don't do drugs. Make sure you're at a healthy weight. Don't take any medicines that can cause an abnormality. Make sure you're exercising. Make sure you're taking your folic acid. So a lot of this is pretty common sense stuff, but we'll really go into this in my patients that have these medical conditions at their preconception visit. And not everyone has to have that, but it's just nice if someone has a medical comorbidity or is ill. It's great if they come in. STD screening is pretty self-explanatory. Routinely, we don't always recommend HIV or syphilis or Hep C. HIV and Hep C should be tested at least once in an adult life, and then we test more often if someone is at a higher risk. Patients that are at higher risk, there is an increase in syphilis nowadays, so we are seeing a lot more syphilis. So definitely in patients that are with a new partner, we do recommend syphilis screening. And then chlamydia, gonorrhea, and trichomonas are all vaginal infections, so we test those on a vaginal swab or in a urine. We're almost there, guys. So as far as vaccines go, we do Tdap. That's a big one during pregnancy. Every pregnant woman should get that around 28 weeks. A lot of patients, they're like, I don't want it, it hurts. Well, it hurts a lot more having a baby. But the vaccine, the importance of this vaccine is kids don't get vaccinated against whooping cough until they're 3 months old. So, kids don't get their vaccines right away. Whooping cough is a big cause of NICU hospitalizations and admissions for kids less than 3 months. So we do recommend something called cocooning. So every person that is in contact with a kid should just be up to date within their 5 to 10 year guideline for their Tdap, but every pregnant mom should get it because then they'll make antibodies against whooping cough, and then that will lead them to pass those antibodies to the baby and give the baby some protection before they get vaccinated. So that's a big one. I feel like I'm fighting a battle nowadays because no one wants to be vaccinated, but I try really hard. Gardasil is the HPV vaccination. We do that in kids that are 9 to 14, only get 2 doses, and then 15. The big thing here and the big change here is that we now allow to 45. It used to only be 26, but it's a really good vaccine that helps protect against cervical cancer, genital warts, and then some of the oral pharyngeal cancers that we're seeing more nowadays, we're seeing are related to HPV. So it's a big deal. If you have a loved one that doesn't want to push them towards it, it's a big deal. And people will be like, well, I already had HPV once and I had abnormal Pap Smear. There's a lot of different strains of HPV. So even if you've had it once, that's okay. That doesn't mean you can't get the vaccine. Do recommend a flu vaccine annually and even during pregnancy. And we actually even do recommend the COVID vaccine even during pregnancy. I was pregnant during the pandemic, and I was like one of the first people in the country to get it while I was pregnant. And I'm on this registry, and they still text me today. They texted me and said, "Did you get your booster? Is your baby okay?" So they've done, it's been pretty good studies. My kid's fine. Most, we haven't seen any complications. What we have seen are complications of people that get COVID when they're pregnant. They're far more likely to be hospitalized and intubated and on something called ECMO, where a machine does the work of your heart and lungs. So it's very dangerous. So we do recommend that vaccine. I'm pretty sure that everyone that's going to get it is everyone that wants to get it is going to get it already, but I don't think I'm really going to swing someone who is pregnant into getting it if they haven't gotten it already, but I try. Okay, that's my baby. So that's Lena. She's a good girl. Any questions, concerns? I liked that we were able to kind of stop and talk a little bit during, but if anyone has any other questions. I'm just over here at Christ. I have a lot of partners. I think there's 7 of us now that are in the office and 4 of us that are just on regular. So we've got a big group. And we will see anything from prenatal care, we'll see well women visits, we'll see problem visits. So I really like my group. I'm really happy here. I'll probably be here for a while. So any other questions, concerns?
Hot flashes ever go away?
They should. They tend to, but they do tend to nag on a lot longer than people anticipate. Like a lot longer. Yes, then that's what the data says. And I think, again, we need to do better for women and figuring out the best solutions. But a lot of patients really do well on like the antidepressants and the gabapentin if they're past that window. So definitely see someone about it. We can do better for you. Yes, ma'am.
I know that I'm late.
Oh, you're fine.
I didn't, because I really have never dealt with hormones. I
Okay.
don't understand them until recently.
Okay.
And I didn't expect it in the 7th decade of my life, you know, so I don't, my mother, she was 100, she left here, never had anything. Sweats, none of that. Her mother was 101, she never had it.
That's a good
You know,
gene.
Yes.
And I all of a sudden did, but it was
Oh, no.
because of something happening in my body. I didn't know what it was. I was like, but I have had many friends tell me about it. It's a nightmare. It can be. First time it's at night to wake you up and what have you. And it never had happened to me. It hasn't happened again. That's my diet. I changed it. I do some things. I stop.
Amazing.
So, yeah, and I still don't have them, you know,
That's
but
amazing.
I want to understand more about them.
Yeah.
Because a doctor prescribed something for me that was wrong. And I, by the grace of God, I didn't use it. They were patches, you know, that she thought would help or whatever.
Yeah.
And I was like reading them, and it depends on what you have in your body, how it can really be a problem.
Yes.
And when she realized it was a week later, I still hadn't used them. She told me, please don't.
Oh, wow.
Yeah.
It's good she
Yeah.
called you then. That's
Exactly,
good she called
exactly. No, I had called her.
Oh,
you
good.
know,
Okay,
and
good.
But it was about something else, but I asked her what had, and she realized, you know, that's made a mistake sending it to me.
Wow.
But I wanted to learn more about that, especially after that.
Yeah, yeah, of
Because
course.
you need to know, you know, because,
You
you
do.
know, it's the only body we got.
Yes.
So we move around in here, you know.
Yeah, I'm glad you're feeling better.
Oh,
though.
So what did you change?
Yeah,
My diet, I don't eat meat.
You stopped
Mm.
me.
I stopped red meat especially.
that's
I
helping
do
you.
still do fish. It's only
That's
been since
amazing.
April
Wow.
of this year. That was on, yeah, I just eliminated it. And then started on cruciferous fruits and vegetables, as they call it.
Yeah.
There's a Dr. William Lee. Have you ever seen him? He's amazing. He's on YouTube. He's on Rachel Ray.
Oh,
Everybody.
wow.
Yeah, just basically sharing a lot of information, good information
Sure.
that I never heard of as far as the
Yeah.
things that go on. I mean, I came from a family that didn't have it, but still, I want to understand more.
Yeah. Oh,
We
that's
can really
wonderful.
learn a lot from television now.
Yeah. Oh,
And
that's
you just put his
amazing.
name in and he'll pop up there. The conversation, and I like it because he's not only a medical physician, he's a scientist. He has a foundation. He's done studies for almost 4 decades. But he's funny also. So he makes you think about your body and what's going on, but you know what to eat and to feed it to stop. It was really, it is awesome. And I had never heard of anything. I looked at a song on Rachel and what have you, but he's basically sharing things like soy that they told us that was bad for women, and it's not, it's actually good.
Yeah.
It's turning some things around, you know, so
Oh, that's really
Yeah,
great.
you have
That's great. Yeah.
watch as well as pray.
I'm gonna have to check it
Yeah.
out. That's really great. Thank you for sharing that. And you actually made me think of another point. It is important, especially, you know, if it's something new and you haven't had it like since menopause to get it evaluated, you know, can be a sign of other things. And I think I have a family member that was just told, oh, it's your menopause, and that ended up being a blood cancer. So new onset hot flashes, it's really important to get worked up because night sweats and hot flashes and things like that, especially not around the time. It's definitely worth getting some things checked out because there can be a sign of, that can be a sign, exactly what you're saying, of something else that's not just menopause. So love it. Thank you. That's a good point.
You're welcome. Thank you. I still want to know more, but I'll Google it.
Oh, no, of
And find
course.
that's just certain things, especially
Yeah.
at this stage in your life, but things that start happening, but you kind of expect it because you're shifting, you're moving and whatever. The
Yeah.
past couple of decades, things are changing.
Yeah.
So, and if you don't move, you're in big trouble because it's like breathing. You cannot stay still. You find something, like you said, walking, do something.
Yes. that's
Yeah,
great.
because you have to get up. You got to,
You got
and if
to.
anybody move you, you.
I like that. Let's do that. That's really nice.
She's adorable, by the way.
Oh, thank you. She's sassy. She is
Mhm.
sassy. I don't know. My husband's like, you really don't know where she got her attitude. I'm like, okay. I know where she is actually 15 months. She is crazy. She's crazy. She's still not walking, but now she's doing this thing where she'll squat and she'll stand up and she'll look at you like, do you see that? And then she'll clap. for herself. I'm like, oh my God, you're a handle.
They're sponge too, it's amazing, they're really sponge, what they see
Yes.
and they do, 'cause she saw that,
Oh,
probably,
yeah,
I'm
she's,
sure.
she'll come up and she's seen us, you know, we don't watch TV a lot,
Mhm.
because she's
It could be a
crazy.
commercial, whatever.
She'll come on and she'll hit the on button, and then she'll hit the off button, and then she'll smile and clap for herself. I'm like, yes, good job. They're smart, you're
They
right,
are.
they are too
Yeah.
smart. I'm like,
Yes,
oh,
we need them too, it's universal, what's going on.
exactly, we
It
gotta,
helps out.
gotta nourish them and
Yeah.
foster their creativity, so I'm like, whatever. My husband got really mad at me yesterday, because she was playing with the can baking soda. He's like, why are you letting her do that? She's gonna open it and make a mess, and I said, okay, like, let her figure it out, I don't care, it's baking soda.
They
It's not
usually
like-
play with the boxes and the cartons and stuff more than the things you
Love
got for
Correct. Loves her box, loves her gate, likes to look at her baby. Oh, what's this challenge? I'm like, no, it's not a challenge, just leave it alone. Please don't fall downstairs, babe. So, yeah, she's the best.
So I wanted to know in this slide about menopause, and it said if you have bleeding afterwards. But well, my question was, how do you define bleeding, or if it's little spotting, does that?
I would still recommend, oh, let me get all the way back there.
Yeah.
I would still recommend getting evaluated. Now, the good news is the most common cause of bleeding in menopause is vaginal atrophy. So kind of like when you skin your knee and you touch it and it bleeds really easy, the vagina does that too. So when there's not like a thickened lining and there's no like uterus over there, the blood vessels are open, so they bleed pretty easily. So we see that in menopause quite often. And so that's like, fortunately, that's the most common thing that we see. Occasionally though, we'll see like a polyp, which is almost, I think I'm the only person that describes it this way. It's almost like a skin tag of the uterus. They are more often than not benign. There's only around a 3% risk of it being a cancer, but it's still worth it. If you have a polyp, we should have it taken out. And that's probably the second most common cause of bleeding. Other causes would be like a vaginal laceration. So honestly, I had a patient come to me once, she had sex, and she was like, I started bleeding after sex and I don't know why. She had a vaginal laceration. So we took a look at it. We started on vaginal estrogen. We started her on that Replens, that, vaginal moisturizer I talked about. She never had it again, but it was good to come and get it checked out. Occasionally it can be, urinary, occasionally it can be rectal causes. So it's important to rule those things out. But again, I think the big thing is let's rule out a cancer, because that's the scary thing. Endometrial cancer, the most often way that it presents is with bleeding. And tends to be bleeding that you get and that doesn't really go away. It kind of comes and goes and comes and goes and comes.
I mean, sometimes just, I have a little bit of spotting
Yeah,
every 6-8 months.
Yeah.
Almost nothing. And it
sure.
was just like, oh, it's still thinking about it.
Still thinking about it. So like,
All gone.
Whatever.
exactly. So someone like that, I would probably just do an ultrasound and say, hey, okay, your uterus lining is 4 millimeters or less, you're fine. And I wouldn't torture someone like, I wouldn't torture you with a biopsy if it looked like that, because we know that risk is less than 1% of it being anything scary. But again, I really like Replens. That's actually over the counter, and I think a lot of people don't know about it. It's a vaginal moisturizer. It's very good. The other thing, my gynecology oncologist when I was in resident, that woman is a goddess. She's very smart, and she also did like a vulva clinic outside of the cancer stuff, and she taught patients that had a lot of vaginal pain and pain with intercourse. Coconut oil is a big deal. It is moisturizing and it's well absorbed by the skin, so it's actually really good to use for sex. And with the discomforts that come along with sex, my big caveat for that is please don't use the jar you cook with. Get a separate jar for your activities, if you don't mind. But it is really good and it's very
The
moisturizing.
simple stuff you buy.
Yeah, yes, because even how it changes. Sometimes it's liquidy, sometimes it's
Yeah.
more of like
Yeah.
a
Warm.
yes.
Yeah.
When it's warm, so it will liquefy. And a lot of times, you pull it out, you put it on your finger, you place it vaginally before sex, and it makes a big difference. And even my patients that are like, in their 30s that have pain with sex, and people that are my age, I recommend it too. It smells good. It's not a bottle. It, with the lube, doesn't squirt, and it tends to be moisturizing as well. So that's a really good tool that I think people don't know about. And it just
So it's
smells
okay to
really
put that intravaginally.
Mhm. Oh, yes. You could do like, cooking oil and stuff, like avocado oil, all that. I feel like the best option really is the coconut, because it is the moisturizing effect as well. I think, oh yeah, go ahead.
One doctor recommended mineral oil,
Mhm.
but it doesn't seem to be as slippery.
I like mineral, I really like, I think that, and we actually use that in labor sometimes. Someone's pushing really hard and they can't quite get it, I'm like, let's slip inside that baby out. And so we put that around and that helps too. So it's a little bit more moisturizing than just the lubrication gel that we use. So that is a good option too. I think that, I just feel like I've had really good results with the coconut oil. So if you like the mineral and it works, that's a good option too. Yeah. It smells nice too. So my patients say, we all know, we've all like seen a delivery, at least on TV, if we haven't seen one. There tends to be some poop, and so the mineral oil helps with the smell sometimes too. So it's a little selfish on our part, but we use that too. I know, when you're in labor, like, I don't really, actually, no, though, I have patients that have been like, I don't want to push, I don't want to poop, and it's like, please get your baby out, like, please push. It's right here, like, let's go. Please don't make me vacuum the child out. I don't care if you have a bowel movement, I really don't care. So sometimes you have to lie, no, nothing's happening, you cover it up, but again, it's all just to get the baby out, so. Any other questions or concerns? Oh, yes,
I know I came in a little late.
oh, you're perfect.
Could you do the very first slides that we missed, or
Oh, yeah,
would you?
oh, yeah, I don't mind.
You mentioned something about the fallopian tubes, and I missed that part, whatever it was.
Oh, yeah, I think, so I did this one about birth control.
What's the best birth control method that you would recommend? That's the most effective and safest?
I really like the implants. I love the
Implants,
IUD,
okay.
like from personal experience and from experience with my patients. I really like the hormonal IUD.
Implant IUDs.
Either the one that goes in the uterus or the one that goes in the arm. Now,
Okay.
the next one in the arm,
The
you get in
what?
trouble for that. The one that goes, there's one that goes in the arm. It's like a subdermal implant.
Right.
What I don't like about that one is a lot of my patients have bleeding issues. So generally I tell patients, give it 3
Bleeding from
months.
the arm or bleeding
From
vaginally?
the vagina.
Oh,
So
okay.
I tell patients, give it 3 months. If your cycle hasn't regulated by then, it's probably not going to regulate. The progesterone, because that's a progesterone only, so it's great for people that have had a history of a blood clot before. They're actually a safe candidate for that. Progesterone tends to be safe in people that can't get estrogen. So the implant is a really good tool, but a lot of patients will have heavy bleeding. That's the #1 reason why I take it off. The IUD, there's the Moran IUD, which is the device that sits inside of the uterus. I cannot, they don't pay me to talk about it, they should. I am like their biggest advocate because it works really well. It's local, so people don't tend to have systemic effects. So there's less breast changes, there's less mood lability. There is actually, interestingly, a little bit more acne with that one. Who knows why? It tends to go away after a year. And I had one and I didn't have acne, it was fine. So that's in a small subset of patients. But patients tend to not have periods when they're on that. By 1 year, about 66% of people don't have periods at all, and most women have lighter periods when they're on that. The other cool thing about the Moran IUD, in my patients, for example, that are really unhealthy and have uterus lining cancer, it actually can be used to treat their cancer. So in about 70% of women, it can help reverse and slow down that cancer. So pregnancy can slow down that cancer so that they can get healthy and get well and then potentially get a hysterectomy. The other thing that's really cool about it is, unfortunately, with the obesity epidemic in the United States, I had one of the risk factors for uterus lining cancer is obesity, and I had a 25-year-old with uterus lining cancer. That is exceedingly young, especially when the average age for diagnosis of this is in the 50s to 60s. I was able to put in an IUD. We did sampling every 3 months until it was gone. She got pregnant, and then after that, then we had to have a talk and continue monitoring. But it's a really cool tool that's not only just used for birth control. It's also actually used as a treatment for endometriosis. So people that have really bad painful cycles, it's actually more effective. Some of the studies are suggesting than oral birth control pills. So it is an awesome tool. I really like it. People always say, oh, my cousin, it went through her uterus. That could happen. Tends to be less likely. The risk of that is about 0.1%. I will say this. I think that if you have a gynecologist place it, you're a lot less likely to have it in the wrong place. Because I feel like uterus everything, right? I know where that uterus wall stops. And so we tend to not have that happen as often because we're more comfortable with uterus. Other specialties can place it, but I would recommend if you or a loved one are getting that, just have a gynecologist do it. We feel the uterus a lot more often.
And the other thing is that, you don't need it, if you're doing an implant, you do a cut. Right?
Yeah, you just do like under the
I
skin,
know.
but it is harder to take out. Yes, exactly.
Yeah, well, I have a different kind, but I understand. I have a monitor
Gotcha.
for
Okay. Okay, gotcha. Oh,
But, you know, they have to go in and out and
Yes,
every 5 years because
Ah.
the batteries don't work right. I mean, I
yeah.
wish they would forever once you got them.
Someday, we're gonna do better. But yeah, I would say that those are my favorite. And then, you know, people are like, well, I really want my fallopian tubes out, but people don't always account for the fact that if you've been on birth control your whole life and your menstrual cycles are controlled when you're on your oral birth control pill, your period's probably gonna be different once you are off your oral birth control pills. So a lot of people are like, they took me tubes out, now my periods are bad. And I'm like, oh, it's probably more so that you're not on the hormones that were regulating your pills, and now your periods are bad, or regulating your cycles, and now your periods are bad. So there is some, you know, some women, that's a great option, and I will take anyone's tubes out that wants them out. I am happy, but I do counsel patients, hey, we may have to put you back on birth control pills, but again, they might be to regulate your cycles if you have bad cycles. Now, someone can get their tubes out, and they're fine, and they're happy, and they're dandy, and they're perfect, and I don't see them even though they should come in. So, you know, that is a very good option. And then for women that have perfect periods that don't need anything, again, the vasectomy is a good option too. Yeah, I said already, my husband likes to do that, so. Any other, oh, the next slide we talked about.
Was that the first one?
Yeah, actually, the one
We
before
started
that
with
was
that
just, oh, this just kind of went through like all the things. So this was kind of an overview of all those other sites that we talked about. Oh, yes, ma'am.
Yeah.
I like the watermark, the breast cancer women. So
Right.
generally recommend an annual breast exam. We also recommend something called breast awareness, meaning like they used to say, oh, you gotta do this like special exam every couple of weeks. We don't really say that now because that was leading to us, again, over intervening and being overexcited about things. Now we're saying, hey, if you're in the shower, take a feel. If you notice something that's not there, come in, we'll do an exam. And then oftentimes, depending on how old you are, we stratify. We may say, hey, let's wait a menstrual cycle and see, or we may say, hey, let's do a mammogram and an ultrasound. So we really do practice breast awareness, and that's really what that term means. It's just saying like, hey, this wasn't there last month. I should get it checked out. And then the breast exam, we mentioned earlier, a lot of people don't know that they need it under age 40, but you should have one every 1 to 3 years. And I think the big take home too, that I mentioned at the very beginning of the talk is like, people think that, okay, I don't need my Pap Smear every single year. I don't have to go to OB. There are components of the exam that you don't need every year. And so that's why it's really important. You still should come every year, but there's components that we don't do. And even now there's some controversy about like, does everyone actually even need a pelvic exam because they're uncomfortable? They haven't really figured out enough, like, are we catching enough abnormalities when we do these exams with our fingers feeling the lining of the uterus? Are we catching enough abnormalities, or are the ultrasounds more helpful? So that's still a little bit controversial. I don't like to do pelvic exams on patients younger than 18. I just don't think it's nice unless they're like bleeding really heavily and I need to evaluate them. So definitely we really are starting to tailor more per the age groups and per the needs of every visit. Yeah. And then I think that my first one was just a yes. And then that's it. Yeah. Thank you guys for coming. This was really fun. I was nervous, but you guys made it a lot better.
Yes, you were great. Thank you.
Thank you very
Lot of it
much.
got passed on.
I know, I'm giving you guys homework. Tell your people